Last session of the day. Just a reminder, 5 o'clock we've got the speakers forum. Please bring all your questions, and we'd love to see you there. Our next speaker, Dr. Margolis, will be lecturing on diagnosis and treatment of ischemic osteonecrosis on the human jaw. He was the past president of IABDM and has lectured all across the United States, Canada, Asia, and Europe to many different health organizations on topics of the tube-body connection, the effect of root canal teeth on the overall health of patients from ischemic osteonecrotic disease. Dr. Margolis.
Gosh, thank you very much, Boo. Well, good afternoon. This is the last session, and I want to thank everybody for being here. I want to thank Dr. Bocot, who is my oral pathologist. He has retired, and he's still writing chapters and books and doing a pathology book of his own. So many of the slides in here, he and I actually did this lecture together many years ago, and it actually holds true because this is the controversy. You know, traditional medicine and dentistry have begun to recognize the potential inflammatory effective connection between the oral systemic part of the body and degenerative diseases. The mouth bacteria seems to be a major role. We hear about this in perio, but we don't really hear about this in the bony structures of the jaw. So if you take a look and you look at this x-ray here, it looks pretty good. This is the bone that was radiographed, and this is all ischemic osteonecrotic bone. So the side effects of dental procedures done daily throughout the world are not typically considered a source of disease. How many people here use epinephrine on a daily basis in their practices? Do you use just anesthetic with no, who uses anesthetic with no epinephrine? Okay, well, if you want to try to avoid ischemic osteonecrotic lesions to develop, think about running a 100-yard dash, and I'll take the athlete that breathes instead of the one that sits there and holds their breath for 20 or for the 100 yards. That's what you're doing to your bone. You're cutting off the oxygen and you're preventing the toxins from being cleared out. So we're thinking outside the mouth, the focal theory, infection theory, and you got Western Price, my personal hero. Traditional medicine and dentistry actually believe this because we pre-medicate people with heart conditions, kidney problems, artificial joints, and other conditions that may be affecting your overall health. So we pre-medicate. Last lecture, somebody says, well, I try to get rid of antibiotics. Let me tell you something. You got to cover your butt, because I was told we're not allowed to say ass. So I won't say that. So you got to cover your butt. You can always prescribe the antibiotic, and the patient doesn't take it 25% of the time. Realize that. And so what you want to do, the protocol I will do with an antibiotic is I start them a day or two before the surgery, and I put them on an antifungal. Now, diflucan's really rough on the stomach and the intestinal tract. So I use FNG from Des Bio. It's a homeopathic, and it's a liquid, and if you're using a homeopathic, you got to hit it 50 times before you use it the first time. And then after that, it only has to be done 5 to 10 times, no more than 5 drops. Because if you do 5 to 10 drops, it's more than enough for an 8-ounce bottle. So when we go ahead and we start looking at focal infection theory, you have a source of infection become a health interruption in part of the body. Materials in your mouth can also cause this and affect your intestinal tract, muscles, joints. And the remaining periodontal ligament may interfere with your energy flow. That's why when Vance was talking last hour, he was saying you got to clean all this out. And that's what you want to make sure. And impacted wisdom teeth, it can be a problem. And that's one that's overlooked quite often. So what we have here, we have the cone beam. How many people have cone beams in their office? Okay, great. How many people have a cavitat? 2. Cavitat was a great machine. I still use one almost every day in my office. And I'm going to explain what happens with the cavitat. And we'll go through that. So over here, you got the very thin slices I've got to get used to this. The thin slices are here in some of the CTs. I'm going to show you a different CT, which is a Galileo Slater, and it gives a very good view of what's going on in the mouth. Over here, you're looking at quantitative ultrasonic sound, which is what Dr. Bocaux calls it, and there's normal trabeculae, and then down here, it's low density, and this is blown out cavitation. So, of course, I'm the only phone that's ringing, and it's over there. I apologize. So, this is a cavitat full screen. And when you have a totally healthy bone, it's going to be a 0. This is broken down a little, and this is a 2. If you have a 3 or a 4, that's going to tell you that the bone is desiccated and it should be a surgical site. Over here, we go through, and this is a lower right of somebody. There's the root canal. It's a relatively young root canal. It was only 6 months old. It's already starting to break down here. And the cavitat, you can take a look right here and you can see a lesion. I'm going to show you how to use your CBCT to show that there's a lesion there. So the conditions of missing teeth, root canals, different restorations and appliances may accentuate some of the problems with your bone. So we have a retrospective study that we did, Dr. Bocaux and I. We put together results of patients' subjective complaints. We looked at the ultrasound. We looked at the CBC, putting the results together. We got subjective complaints, sites suspected of lack of dense bone, and then compared the two. All treatment plans were presented to the patient prior to the surgery and signed. This is really important. We're finding mistakes. I got new employees. Before the patient leaves, I try to get them to sign the treatment plan, but a treatment plan is not a consent form, okay? This is really important. I had a friend lose his license because he had all the treatment plans signed and agreed to, but he never gave a consent form to do the surgery. And he lost his license for that. So, always have a consent form. What happens if a patient comes in, you've given them Valium, they show up, and they didn't sign the consent form? What do? Come on, speak. Send them home. They're under drug influence. They are not competent, and unless their spouse is willing to sign it, then that's okay, or something like that, or guardian. But if the patient took a drug, they didn't sign the consent form, send them home. You may not touch that person, or you can lose your license. It's called assault. Okay, so here's the methodology. We did histological biopsies. This is from Jerry Bocaux's lab. And what you'll find, it's an acute expiration of the periapical granuloma, suppurative pulp necrosis of the apical canal, endodontically treated tooth, and there was a fibrogen sludge in there. Very nice thing, and the other part that they like a lot to see is there was no cancer present. That's one very nice thing to have in there, and that's what you want to look at, but generally speaking, you don't do it. Now this comes from Dental Connections, who's sitting in the room right now, Blanche Groovy. I love this. My naturopaths go ahead and they want this. They want to find out what is the offending bacteria or virus that they found in the sample. And we're going to go into that a little later more. So I'm going to give you a clinical case. And this is about a young lady, 44 years old. She was very sick. She suffers from dizziness, fatigue, tired all the time. And what does she do for a living other than being a mom? She's a gymnastic coach. She was semi-professional when she was younger. And now she's getting dizzy. Doesn't work well. She has neurological pain of her ears, TMJ. Good luck having a bilateral TMJ and maintain your balance on a balance beam. And sinus problems, etc. She was very anxious coming in. She competed in gymnastics, mother of two, time of treatment, going through a divorce. Her husband was just plain tired of her being sick. And her doctor couldn't figure anything out. And she went to a naturopath, says, go see Margolis, he'll figure it out for you. So we went ahead, and I got to tell you, it's not a perfect world. Before I get started, these cases don't have histological reports attached to them, sorry. But we got some DNA things that's going to go. The reason was that the cost, I would have to pay both labs to run the reports. So that's the reason we're there. So the only thing, this is what comes from my old soft dent, they dropped the crowns. Each one of these had crowns on them. And by the way, the crowns were all porcelain fused to metal. So if you have porcelain fused to metal in your mouth, it's very rare that the metals are all going to be balanced. They're not done all the time at the same time. And even if the labs do it, the metals are not always in the right composition. And what happens when you have dissimilar metals in your saliva? Galvanic charges. Galvanic charges affect amylase. What's amylase? The first digestive enzyme released in your mouth. And if that gets neutralized, we know all our patients chew their food 35 times before they swallow, right? We all do that, right? Every single time. So by the time you take the amylase, you disable that, you put it into the gut. Your gut's supposed to have a pH of what? Take a guess, I'm showing you. 1. It's supposed to be very acidic. And what do we take if you have an upset stomach? Oh, you take Tums and neutralize your acid. Now you're not going to break down the food. And then you try to digest that in the digestive tract. You got what? Leaky gut syndrome. So I regress a little. Look at her perio. Perfect. I mean, this girl took care. She was a very pretty young lady and just felt crappy. Why? Because of this. Now, every CBCT has a way to trace this nerve. Make sure you trace that. So now, when I have a patient like this and I got a purchase sitting right next to the nerve, I'm going to tell them I probably won't get that out. I don't want to split that nerve. I got lucky on that one. The granuloma on that, okay, which way did we go? I got to go back. The granuloma was so intact here, it came out with it. I was lucky. Simple as that. So we're going to go through this. There's the cavitat. It shows that it's broken down. These are 3s and 4s. 3s and 4s. So this is your upper right, your upper left, lower left, and lower right. So when you put it all together, that's what you have. You have this here. Now, the grade up here is more above the tooth. So that tooth was actually pretty well intact, I think. I could be wrong. If I am wrong, I'll tell you. And then over here, you have a 0, a 1, a 3 due to the root canal, and there's your third molar area. And on the lowers, there's your granuloma over there, down here, everything there. Now that actually looks pretty good, but take a look at what the cavitat tells me. That's a grade 3. But you can see that when you go into your CBCT. So we come in here, we do the location, we get a grade and we get a density. We get a grade and we get a density. Now, these are the higher numbers. When you do a density on a cone beam, does not distinguish between the bone or the tooth, whereas the cavitat only measures the tooth. So when you're looking, cavitat only measures the bone. Thank you for that face. It's pretty cool because it just measures the bone, and you'll see these higher numbers are where the teeth are. So that can get confusing when you're doing a CBCT. Over here, the reason the two technologies don't always agree, I just told you, and then therefore without a CBC, the cavitat's no good. I had a guy call me up, he had an action taken against him by a state, and he wanted me to back him up. And I said, well, send me out the cone beam or the pano. And then the other, he said, well, all I got is a full series of x-rays. I tape them together, though. It doesn't show the whole jawbone. There's no way I could defend him. So we're going to go through each one of these. There we go. Take a look. Did I do too many? Let's see. Yeah. Okay. So you can see the high grade over here on these. Sorry. Not used to this. Okay. So these are high grades, but this is solid. Root canal. Diffuse multiocular radiolucency over here. Bone density less than 1,500, and symptoms. Take a look at what we got here. Be prepared to be able to speak to your patient about the DNA results. Because take a look at this. Oh, dang. I'm going to get this right. HPV, HPV, HPV. I had another patient. She was an older woman. She was a grandmother. And her husband wanted a divorce. Why? I'll give you a hint. HPV, HPV, HPV. He accused her of having an extramarital affair. There was no way this woman ever had an affair with anybody. And I said, how many grandchildren do you have? Well, nice Mormon family, 16, going on 20 in the next 6 months. I said, do the kids ever go to daycare or go to church and drink from the same cups? Yeah. I said, that's probably how your grandma got it. Your wife got that because the kids were kissing her. So be prepared to understand what each one is. Blanche, do you still give out a technical book with your stuff? Okay. Read the book. When you get these things, read them. If you have questions, call Blanche. She's really good at answering them. You can call me too, but I'm not as good as she is on that. So, but anyway, it's really kind of exciting, and you got to come. Okay, so when you take a look at HPV 16, cancer-related sexually transmitted virus. So this is what this guy's thinking. And then Athenomyces, common clinical Athenomyces is cervicofacial, thoracic, abdominal, pelvic, which obviously pelvic is only going to be female. And then you come on down here for other things, diarrhea. And this is why the naturopath wanted to know what were the bacteria and viruses that were present so they could come up either with a remedy or with a medicine that they could come up with. Now, the histology is kind of interesting. This is where Jerry came in. He started showing me the fibrin sludge. The bone is here, but you don't really see any black spots in here, which is viable bone. So you're missing the osteocytes. And then we go to the next area for 15 and 16. So positive high numbers over here. This is bone density, the BD. And so chronic ischemic bone, whatever. Same thing. Now we're down here, and then you can take a look at these guys. We're at 17 and 19. These are grade 4. That's just soup when you get down there. And all three of them, because you got the 2 root canals and 17, you can see the outline here. And this is what came up. Blanche has sent me some that have 35 different bacteria that are surrounded. At that time, they were only doing 110 samples. And what I did for my very first 90 cases, I took each one and did a spreadsheet. And I marked down every one of these that was positive for each location. And Hal Huggins was alive at that point. And we had that meeting in Colorado Springs. And so it came about because Hal asked me, why haven't you come to any of my meetings? I said, you always have it on a Jewish holiday. I can't make it on Jewish holidays. And so what did he do? He told me to set the date. And we went out in August because that was a cooler part than it is in Phoenix. And my wife told me I wasn't going to go, and I said, no, you don't get Hal Huggins pissed off at you for not showing up. So I went through and I had a percentage of each one of these. And he turned around to Robert, and he says, why don't we have that? So I think it would be a great idea to have a memory bank on all these and see what the percentages are. It'd be a really good paper to do. Anyway, so all these, if it's over 9.5, it's red. So you got normal oral flora too. So you find these things. And that was what sold me on the DNA approach, because it shows the good stuff along with stuff that's not so great. And black pigmented oral bacteria associated with periodontal disease. There was one case that I was doing on a cavitation, and we're going to show you one in a moment. And I opened it up, and all of a sudden this black stuff comes rising up. I thought it was the thing coming out of one of those Hollywood movies, the thing coming up and engulfing everything. And it turned out, before I was alive, that's a long time ago, people took antibiotic and Vaseline and put it in extraction sites. Yes, I asked Jerry about this because I said, Jerry, this is the grossest thing I've ever seen. And it fermented, and it was really very, very toxic. We cleaned it out. The patients got really better. Here's the histological stuff. There's some gutta percha over here, and you can see the residual pulp tissues that were left inside. So there we go. These are the specimens, high positive, bone density. Less than 1,500 is not good. And so we go in here. Now the reason the other numbers were higher was because there were teeth involved. And then we're down here, 30, 31, 32. Here are your bacterium that are above the 9 and 9.5 level, which they established as toxic. And you got to take a look at this as the effect of all the different ones building up on one another. If there was only one or two here, fine. But it doesn't all go that way. So we come in here, we look at what we found again. Again, here you have HPV. You've got Streptococcus, Athenomyces israeli. And then the histology, there's a live cell right there, you can see it. I was looking all through the slides, there's another one up there and there, but most of this is non-viable. Neutrophils, red blood cells, necrotic debris surrounding space from which gutta percha has been removed. So as I did the processing, the gutta percha came out. And the bone density, again, is very, very low. So here you go, you come in here, and you have your densities. And you can see that, of course, these look good, but it's because you're measuring the tooth, not the bone. And then the follow-up. She kind of disappeared on us before we got to implants, but a lot of my patients come in, they're going through a divorce because they've been sick for a very, very long time. Most of them, 80% at least, are women. While working with a naturopath, her symptoms diminished. Bearable levels, looking forward to getting her zirconium oxide implants. I don't know what happened to her. Though she gets tired by the end of the day, she doesn't describe her condition as chronic fatigue, fibromyalgia. She says, I'm tired because I got 2 daughters that I'm carting around and taking care of, and the husband kind of disappeared. All her TMJ problems, all the headaches were better. We gave her a night guard to help with the grinding, but she wakes up looking forward to the day. And that was the last time I had seen her. So we see what we are taught to look for. How many people were taught to look for bone lesions in the jaw other than maybe an abscess around a tooth? Were you taught to look for cavitations or anything like that? No. I don't use the word cavitation in my notes. It's always, if a person has pain, it's chronic ischemic osteonecrosis. Or it's just plain osteonecrosis, dead bone. Chronic is a different type of word, long-standing. Ischemic is lack of oxygen. So how do we know where a lesion is? And we're going to go into some other things. So what I have here is when you're looking at the maxillary arch, I'm going to go through this because it lays down foundation. I'll do the lower, and then I'll get into the 3D cone beam. So the shape of the arch bone you want to look for. We're going to show that in the cone beam. Where are the roots of the most distal molar on the maxillary arch? Raise a flap from 2 or more teeth in front of the lesion through the distal aspect of the retromolar pad so you can fold it. Make sure you can expose the bone, keep the papilla intact between the remaining teeth so healing of the gingiva papilla are intact, healthy, or healing. Clean off the periosteum and any other tissues on the surface and look for bleeding points. This I'm going to show you in the movie. That's really important. Healthy cortical bone does not bleed. Remember that. So you can use a periosteal elevator because it's usually very thin bone. You can also use a piezo or rotary surgical handpiece to open directly in. I'll use a claw spoon to collect. and clean out the site. Boy, there's so many ways to clean out the site. I got a Photona laser, and you can place that in there to help clean it out, but you still have to go in there with a claw or something. I like using a surgical burr, the 8 or 10 size, but I don't push on it. I guide it along the tissue unless I'm removing the cortical bone to see better on the lower. But you don't have to push it. You just have to just touch it like you're an artist. So on the mandibular, examine your CBCT, really good. You want to know where that neurovascular bundle should be outlined. Measure the distances you have. The burr, surgical burrs are generally 6 millimeters. If the bone is at 8 millimeters, you got to be really careful because 2 millimeters is easy to slip. But if it's 14 millimeters down, I feel like I'm on a freeway. Okay, and then you raise a flap, 2 or more teeth in front of the lesion. Sometimes on the lower you'll have to go 3. Make sure you can expose the bone, remove the periosteum, keep the papilla intact. And by saying papilla intact, sometimes you cut the papilla in approximately. Sometimes you just go straight across and keep the papilla intact totally, and then you just suture it so it stays together when you get done. But you just have to make sure that it heals properly, and some people I've seen take the papilla and they throw it out. That's a no-no. Know where the mental foramen exits the mandible. It's really scary when you retract everything and you're not expecting to find the neurovascular bundle at the bottom of that. And it's okay. You have to dissect it out so you're not going to tear it or put stress on it and damage the nerve. And I've done that multiple few hundred times actually. But you just have to be careful, know where everything is, and watch. This is the coolest part, and you'll see this in a few minutes. Watch the surface of the cortical bone. Look for bleeding points. Healthy cortical bone do not have a lot of bleeding points. You might see 1 or 2 come up, but you don't see a whole pattern. And how thick is the bone? When you're going on that mandible on the lower, it can be pretty thick. It could be 6, 8 millimeters thick. It's what's underneath is bad. So you can have a flat table, rounded, where are the distal roots of the tooth in front. You will enter into the lesion, lift the cortical bone, and attack tissues. It should be attached tissues. I attack them when we get done. Intact and obtain your biopsy. So, little discussion here. This is Sam. Sam is my son. When he was a teenager, he liked to party a lot, and I told him, don't party a lot because we're taking your wisdom teeth out. Well, he didn't live a good lifestyle or anything. He was not very healthy, and he did a lot of little drugs that we won't talk about. So he got some infections that he was having pain, and he says, Dad, I think I really made a bad mistake. He came to me. Now, the movie you're about to see is only the 2nd or 3rd time I've used this camera. I have to apologize. My head gets in the way. You can cut it off later. But the whole thing is that it does a really nice job, and I want to make sure that everything goes well. So let's see. Okay, here we go. So, first thing, yes, I'm very grateful. What you want to look at is the lower right spot, and that's going to give you the structure of the 3rd molar up there. And now, what do you look and observe? You see, here's the 2nd molar, and to get to the 3rd molar, it curves in, even on both sides. So when you come up here, you're going to have to see where that extends distally, and that's where you want to take your scalpel, come in, and then fold down. It seems like common sense, but a few people lose that. Then we go back to here, and we come in here, and we can see how far distal that will go. And if you want, you go to your density measurement here, and you come over to here, and come on, give me, oh, turned off. Let's get that back to where I wanted it. Come on. Okay, so we come to this, and we come over here, and it gives you a number. Your number is right here, 1253, way lower than 1500. So I'm not going to go into a few other things at the end if we have it. Now you can see over here a little spot, but over there, what happens, you check the density, you come over here, and that's going to be 1400 below. Doesn't show up very well here. It shows up great on the computer, of course. And then when you come over to this area, this is the same spot. You have 1341, but what you can do, before you open anything up, you go like this, and you come down here. My distance is almost 17 millimeters. So now I know that that's where the density is. That's the distance down to the nerve. And I suggest that you use that because I had one damaged nerve out of, I think we guessed 25,000 surgeries that I've done. I've had one damaged nerve. And had I done what I just showed you, it would have never had happened. So let's see if we can get the movie going. All right, here's my son. Let's get over here. Stop for a second. Okay, so I told you he's 32 years old. He's getting pain that's causing headaches, jaw pain, and some numbness down the right side of his body. And this was Monday night. So we go ahead and we're starting to release the tissue and then come up. Now, if you do both arches, I recommend that you use a new scalpel for every quadrant that you're doing. He had very, very thin tissue, and it did rip a little. I wasn't too happy with that, but when I sutured everything up, it all went back to place, so I was pretty happy about that. And he is not very comfortable watching this because the way it was set up, he could see everything, so we got him glasses that he couldn't see. They were dark. There's the cortical plate that we're starting to uncover. It's not always so easy to get that, and my head hit the stand, so you see a little movement there of the camera. And then we're just working it, working it, working it. Try to take your time, get all the way down there. Let's see if we can get this guy ready to stop. Okay, let's stop here. Look at this spot here, then I want you to look down here. This is the bleeding spots that I'm trying to tell everybody, take a look and examine. Come on, start up. It says play. Okay, so those are the bleeding spots. Look down there. Look where that forms, and that's going to tell me where I'm going to take either my drill or my piezo art to form the top entry into the lesion. The lesion is going to be right underneath that. Let's see if we can, I'm not going to touch anything. I'll watch. I was going to try to speed it up, but I don't want to do that. There's my head in the way. But there we go. We start with this, and this, the reason I like this, and by the way, I have no interest in financial interest in any of these things, but you start and you put a groove over here. It doesn't have to go deep, and you gently work it back and forth, and that bone was about 5 millimeters thick before I could get down into the lesion. And then, as that goes, all of a sudden you're going to feel plunk, and you're in. Then I come over here, looking down here where that bleeding point was, and just keep on going up and down. Take your time. your patient's not going anywhere. I promise you, they're not going anywhere. Now, prior to this, we had already drawn blood, and we're using a bio-PRF from Rick Morin, if anybody knows who he is. And Rick has a product that from his PRF he can make sticky bone. Osteoprof is the artificial bone that he sells with his unit, and it's really, really nice. Now, sometimes when you get here, you have to go up and cut a little more tissue. But he's got a fat cheek. We'd already done the upper. There was a little swelling already, so I'm trying to avoid that. I got to be nice to him because he's letting me do this for this convention. So, and what's cool about him is that he hasn't done editing in 4 years, and I don't know how to edit. And he took a day off, and Wednesday night he had this done. And he had done the upper arch, and I said, no, you did the wrong side. So he had to go back and redo this, and before I left, I picked it up, and I was extremely happy because it shows what's going to happen. So you still have some of those bleeding points in there, and now you got bleeding there. We're going to come across this way, and that was the original one I showed you. So now you take a periosteal elevator, you're going to lift that up, and there, that's where you want to send in for a sample. I didn't hold it up. There was a lot of stuff hanging down. I call that crystallized bone because it looks like a crystal. And then, come on. I opened it up a little more so I could get my spoon in there. And there it is. Now, what I try to do is I just try taking the spoons or periosteal elevator, but these are spoons that have claws on them. And I actually had my armamentarium stuff all printed out and left it at home. Typical Michael move. But it will start lifting. You start at one corner and all of a sudden everything starts coming out. Normally what I try to do in any of my biopsies, I take a pipette and I suck up the blood and I put it into the sample, even if it's histology, because it has a lot of information that Jerry likes, and I know the DNA people can get a lot of information from it. You'll usually see oil come up, which I believe is a cholesterol that gathers a lot of toxins. And we just keep on going. Now, what you're going to see here in a moment is I'm going to take a round burr and I'm going to open this up. I want to see the entire lesion if I can. I don't want to go blindly into stuff, but you want to make sure that you don't hit the back root of the tooth. So I keep the round burr up at the thickness of the cortical plate. And the round burr is usually, depending upon 4 to 5 millimeters around in a diameter. So that way you can get in there and clean it. Now, if you're going to use a photona, after you get this stuff cleaned out, you can put a photona in there and it will clean out the soft tissues. Keep it wet. Keep it very wet. And the reason I say photona because I'm not familiar with the other. That's a 10 round burr. And notice, I'm not going real deep. I'm coming down there. But I've used surgical burrs on this for over 20 years. And what I'll do is I'll turn off the burr. I don't know if I did it on this one. And I'll just feel the bottom of the lesion to make sure I'm not through into the nerve. And then I'll turn it on and I'll just lightly, I'm not pushing down on the bone, I just lightly go around and clean out the bone and make it angelical white. Because clean bone is angelical white. It's absolutely beautiful. Okay, so now I rinse this out with hydrogen peroxide. Some people like to use ozonated water, which is fine. Ozonated water will turn into what? Hydrogen peroxide. I just skipped a step. You can get hydrogen peroxide, food grade, for a few bucks a bottle. Lasts forever. Then I'll go ahead. Is that a nice picture though? Blanche, don't you like that? And this is only the third time we used it. This is the sticky bone. And it's artificial, it's not cadaver. Pardon? It's OSOPIF or something. Sophia, thank you. And then I pack it down. Looks like an amalgam condenser, but it's not. It's for bone. And then I'm going to go ahead and suture it up. I'm going to start using these on most of my surgeries, so that way I'll have a bank of movies to show, be able to teach people how to do this, because you start your first suture on the distal part of that tooth and go into the lingual and come up and tie it down, tack it down. And what I found out after learning to do the keyhole technique, pinhole technique for perio, I found out that many times you just take that first papilla up there that we separated, it laid right into place. I didn't even need a suture to hold it. It just stayed there. And then it just keeps on going. So let me get back to the, that's just, let's get to the end. And there we go. It's all pretty. So that was my lower arch. Down here, office number is 480-833-2232. And it's doc@mydentistaz.com. And if you really want an answer, address it to Jody, Jodi, my office manager. I sometimes get 100 emails a day, which are crap, most of them. So if you really want to get a hold of me, my cell phone number, 602-363-9584. I have had doctors call me when things go sour, and they actually took their cell phone and they were showing me the mouth. And I'm looking at it, and I try to ask questions to help. I want everybody to be able to do this, and the reason for it is I have people who will fly all over, from Europe, South America, Asia, and the United States will come in and see me. And I think that's terrible. I think that the people need to be trained and do this competently and be able to feel comfortable. So one of the things that you need to do is learn how to read the CBCT. If you're placing implants, you have to. Does anybody know what an ostium is? In the sinus, there's an opening. The sinus is the only part of your body that drains up. And if you're draining up on that part of the body, let's see. I'm going to see if I could try to restart this. I don't know if I can or can't. But it's really important that your ostium be open, because if it's not, then you could cause tremendous amount of damage to a patient, which none of us want to do. And it's an anatomy that if you're on a witness stand for somebody and somebody says to you, was the ostium clear? You got to know what an infidibium and an ostium is. And we'll get one up here, because my son has two different sizes, and it makes it a little scary. So he didn't obviously need an implant. But when you know the sinus and you take a look at it, there are a lot of fun things to do. Don't be afraid of a sinus. My son's an oral surgeon. He's inside a sinus almost every day. Of course, your oral surgeons will tell you that, oh, you killed them, but you didn't. So here's the structure. This is the right side of his nasal passages and his sinus. And the ostium is this little hole right here. There is no infidibium. The other side, when you look at that, you come here, he has, the ostium is here. The infidibium is this little narrow way in, and it always will drop at the medial or middle turbinate every single time, if it's normal. The other side wasn't. This side is. If you find a sinus that is really cloudy and it's grayish in here, you have to make sure if you put an implant in that this is free. Because if you put an implant in and this is gray and puts the pressure up, it will clog. It will clog. And now you've got all that infection and everything else in a very warm, 100-degree, moist body underneath your brain. And the way that it will break out is most likely you go up into the sinus, into the brain, and it could be a mess. And you could kill a patient. So you got to know your anatomy on this. You want to know what you're going to do. And if you're going to look at here on density of bone, here's another. You have this, and all this here. Let's see if we have the honeycomb effect. When you have patches here, 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 and here, that's going to tell you it's ischemic bone. So if you don't have a cavitat or anything, you can go in there, you can measure the density down here, and you take this over, and you're going to find out that's pretty poor bone. And when you go in there and you clean it out, that comes out in chunks. Lots of chunks. Well, I know I've gone a little over. I apologize for that. Doc, thank you. Randall, thank you very much for helping me out on this. And if there's anything that you want to know from armamentarium to different things on here, I'll be more than happy to share any information with anybody. I'm signed up with the IABDM and IAOMT as a mentor. So all you got to do is call the office and you get mentored. And the price for that is appreciation. We have to stop looking at, hey, how much money are we going to make all the time? When colleagues are in trouble, be there for them. Blanche.
You know what I always say? You don't want to be the only yellow duck in the lake.
She's right. I mean, I went through hell for 2.5 years because the board gave me an offer. And the offer was to quit pulling root canals and stop doing cavitations, and they will leave me alone, or they're going to take my license away. So I gave them the salute and said, try it, and it cost me $200,000. But you know what? I won. And very few people are going to do that. My associate came to me, he was a nervous wreck one day, and he says, Mike, how can you do it? I said, we have to. That's how you do it.
Right on.
Blanche?
One more thing, if you don't mind me mentioning, in November 11th, 12th, and 13th, I'm teaching the Huggins protocol in Houston, Texas, and we spend a whole day doing cavitation surgery. So if you like this, you can walk over there.
Blanche is an excellent surgeon. She's an excellent friend. I love her to death. Why she puts up with me, I honestly don't know. But there are a number of very talented surgeons here throughout the whole academy. And I don't want somebody walking down the hallway saying, oh, he's the only one to go to. That's wrong. Like Blanche said, we want a lot of ducks in the lake. We want this to be known. One last story. Last month, I had probably one of the greatest experiences ever. A 19-year-old girl came in with her mother. Her left leg was normal size. Her right leg was almost as large as mine. And she was a tall, thin, pretty blonde, and very articulate. 2 days after she had her wisdom teeth taken out when she was 17 years old, her right leg blew up. She was at Mayo Clinic. She was at Barrows Clinic. She was at Memorial Scottsdale Hospital. She's been lymphatic drainage all over the place. They've spent $15,000, $20,000. And she was no better off than when she walked into my office than she was after the leg blew up. I looked at her. Her cavitations were huge. We took pictures and everything. The next week we moved some patients around, got her in, did the surgery on the right side of the right leg, and she came back 2 weeks later, and her right leg was almost the same size as her left leg. 2 days after the surgery, it started shrinking. She goes to her mother 7 days afterwards. She says, "Mom, look, I can move my toes and I can move my foot." She couldn't do that. I asked her what her physical signs was. She didn't even tell me that because she was so used to walking, like that. It was terrible for her. And now she got a job as working in a bar as a server. And I told her, please just start a few hours a day. You're not used to using that leg. But it's normal. And the mom wants to go ahead and get the histology reports that we're going to do and everything else and take it to the doctors who didn't know what the hell to do. So, and 90% of the time the doctor will say, I can't make any money on that. You'd be amazed at how many people I've had people with cancer, breast cancer, upper molars, lower premolars, clean them out, and the cancer mysteriously starts going away. Now, please understand, I work with a lot of naturopaths. So they're doing the IV support, and they're doing colonics, and they're doing all these different things, changing their diets. That was one of the biggest things for that 17-year-old. She had no candy, no sugar, no nothing for 2 weeks. And she said, "Can I go back to that?" I said, "I hope you don't." See? Perfect timing. Okay. Have a good evening. I know there's question and answers.